Welcome to the Beyond Biopsychosocial Training Program. My name is Jeff Hauk, and I'd like to acknowledge my co-authors, Dr. Kang, Philbrook, Jacobson, and Cuddyford. This module focuses on the PROMIS fatigue symptoms CAT and its application to practice. So first we'll cover motivations, basics of the PROMIS fatigue CAT measure, and then applications to practice. Our team was initially not agreed on the importance of fatigue. They were comfortable looking for fatigue on the radar as they started their patient assessments. But our beliefs and attitudes changed. Fatigue is a common symptom in patients with spinal cord injury, multiple sclerosis, muscular dystrophy, and post-polio syndrome. It's also important to measure fatigue as a consequence of stroke. In primary care, at least 1/3 of common symptoms do not have a clear-cut, disease-based explanation, and this includes fatigue. And finally, articles cite up to 70% of patients with chronic low back pain report clinically significant fatigue. This changed our views on the importance of fatigue. It cuts across a wide spectrum of patients. But you could also ask the question, do fatigue symptoms impact my patients significantly? This impressed us. Fatigue symptoms are associated with the risk of mortality equivalent to heart disease and diabetes, and that there's a consistent correlation between fatigue symptoms and lower physical activity. And there's also a consistent correlation between fatigue symptoms and lower social engagement. It's not surprising given this definition of the impact of fatigue on patients. An overwhelming and debilitating sustained exhaustion that decreases one's ability to carry out daily activities, including the ability to work effectively and to function at one's usual level in family and social roles. And this acknowledges both a physical component and a mental component, and that they are intimately connected. The problem is that fatigue is complicated. There's many different causes, and here's a model from osteoarthritis that recognizes that biomedical causes like anemia and hypothyroidism can cause fatigue just the same as low sleep quality or mental health problems, and finally, low physical activity, all separate and distinct causes of fatigue. So what we are learning is many different groups of patients have fatigue symptoms. Often the reasons for fatigue symptoms are not explained in primary care. Fatigue symptoms may have many different causes, and that effective screening and identification of the cause of fatigue may significantly improve clinical outcomes. So our team's beliefs and attitudes changed, and we became motivated to look into fatigue. The PROMIS authors define fatigue as the self-report of symptoms from mild subjective feelings of tiredness to an overwhelming, debilitating, and sustained sense of exhaustion that likely decreases one's ability to execute daily activities and function normally in family or social roles. This recognizes fatigue experience and the impact of fatigue on physical, mental, and social activities. So the questions look like this. How often did your fatigue make it difficult to plan activities ahead of time? Or how often did you have to push yourself to get things done because of your fatigue? And then finally, how often did you feel run down? And you can see that these items cover both experience and impact. At the end of the day, the PROMIS Fatigue CAT included 95 items, and the algorithm worked similar to the physical function scale, where 4 to 5 items usually is what's needed to obtain a T-score. And validation studies were able to demonstrate that a single score really was sufficient to capture both the physical or experience of fatigue and the impact of fatigue on functioning. So here's some data from our rural health clinic in Oregon. Note, similar to the other scales, that a T-score of 50 is the mean of the reference population, which in this case is the US average, and 10 is a standard deviation. Our high scores are worse fatigue and low scores are better fatigue, and a floor effect was somewhere around 20, and a ceiling effect is somewhere around 80. We know that acceptably low fatigue is 55 or lower, and that unacceptable fatigue in our current sample is experienced by around 42% of people attending physical therapy for a variety of orthopedic conditions. At discharge from physical therapy, we can see that low or unacceptable fatigue symptoms are experienced by a majority of patients, and that around 30% had continued to have high fatigue or unacceptable fatigue symptoms. Minimally and clinically important difference has been reported at around 5 T-score points, similar to other scales. Also, you can see here in a variety of health conditions such as cancer, COPD, low back pain, the PROMIS fatigue scales demonstrating the ability to detect change in worsening and improving patients. So that covers motivations and basics, and now we'll cover application to clinical care. Important is the interpretation of mild, moderate, and severe. So remember that low fatigue scores are better and high fatigue scores are worse. So scores from 20 to 55 are considered within normal limits, 55 to 60 as mild severity of fatigue, 60 to 70 moderate levels of fatigue symptoms, and above 70 severe fatigue symptoms. And so this patient's score of fatigue at 65 would be interpreted as moderate symptoms. So let's look at some vignettes to capture what the items might look like for a patient that's within normal limits. So this patient in the last 7 days, Sheila may report she's never too tired to read, never too tired to watch television, almost never feels weak, but sometimes she finds she's more tired than usual waking up in the morning, and sometimes it's hard to get out of bed. Many of us can relate to these perceptions of tiredness or fatigue. So let's shift now to a patient with moderate symptoms. So in the last 7 days, Janet, who has a T-score of 62.5, might report sometimes she was too tired to go up and down a lot of stairs, sometimes she was too tired to do sports or exercise, and sometimes she needed to sleep during the day. All of these seem to have a clear impact on the person's function. And then the last item, sometimes being too tired to keep up with schoolwork, shows a real interference with cognitive abilities, capturing both the impact and the experience of fatigue. And finally, a severe case. So in the last 7 days, Isabel reports almost always having difficulty waking up in the morning, frequency of tiredness. Sometimes she has difficulty spending time with her friends, and sometimes she's too tired to focus on work, and she's almost always too tired to read. So the kind of global impact on both function and experience is well expressed in this vignette. So my patient reports high fatigue symptoms. Now what? Find the cause and try to address it. So we came up with this algorithm as a consequence of focusing on fatigue, where we recognize disease processes, sleep, behavioral health problems, and physical activity as part of a potential cause of fatigue. So the first priority is eliminating disease processes like anemia and hypothyroidism. The second is to look for problems of sleep like sleep apnea, insomnia, and other common sleep problems. A good example is the 55-year-old male former police officer that was involved in a crash about 8 years ago, had seen 7 providers, including an acupuncturist, chiropractor, and a PT, also developed hypertension, gained weight, and was currently considered disabled. His PROMIS scores on the physical function, fatigue, self-efficacy of symptom management, and satisfaction with social roles were all a standard deviation worse than normal. But what was really disturbing was his fatigue score had increased after a few visits by a significant amount. And this led to questioning specific about sleep habits, depression, and aerobic activity. It was clear that he was waking several times a night and then started falling asleep during the day. This triggered a referral back to his provider that ultimately was diagnosed with extreme sleep apnea. Next on the list of possible causes of extreme fatigue are behavioral health problems. We know that situational depression and even more severe depression occur across a wide spectrum of patients that we see. So screening for these is prudent. So in this case, Jamie presented with a past medical history of a right knee implant during high school, a recent right hip joint replacement, and now presented with left hip pain and was worried that she had to have another surgery. We can see here that all of her PROMIS scores are worse than a standard deviation of normal except for social roles and activities. But the high fatigue score caused us to screen for depression, sleep, and aerobic activity. And what turned up on the screening was that she was showing significant depression, and she also tested positive for anxiety. But based on her interview and low self-efficacy scores, the interpretation of the depression was situational depression. So we went ahead with treatment focused on building self-efficacy and increasing physical function. So after 2 visits, we can see that her fatigue scores dropped significantly. This indicates that the diagnosis of situational depression was likely correct. In these subsequent clips, Jamie reflects on how this injury was affecting her.
So if you had to get a flare-up right now, how would that impact you?
Emotionally,
Yeah.
I'd be so sad.
Okay.
Would be really sad.
Yeah.
Because I'd be like, oh, I don't want to go down this road again.
Mm-hmm.
It was very, I was just not wanting to move. I just want to do that again.
Yeah.
Yeah, it would affect my life.
Totally. Sounds like it.
Yeah,
And I mean, I think that's what brought you to physical therapy,
yeah,
was the fear that that would be what it is one day.
it is.
Mhm.
Yeah, so if I can do this and avoid surgery and function really well, take my walks, play with my grandkids, I'm good.
And finally, because of the issues related to low physical activity, which is really pervasive, the CDC guidelines on physical activity have become something that we're really familiar with. And recognizing that as we move to value-based care, embracing these guidelines and working for behavior change with patients has a real potential to increase our value and impact on patients. So let's look at Joanie's case to see how fatigue influences physical ability and health status. Joanie is a 64-year-old female that had recurrent low back pain 8 months status post-laminectomy and L5-S1 fusion. She also was currently undergoing continued treatment for multiple myeloma that had negative effects on her immune system as a result of infusion and chemotherapy. Prior physical therapy interventions were unsuccessful. In examining her PROMIS scores, it was evident that several of the PROMIS scores indicated worse function than might be expected. But what really stood out was her high fatigue scores. And this was matched with her self-report, where she indicated that her peak activities during a week were household ambulation and ADLs, all less than 3 METs. And this was consistent with her performance, where in walking distances of less than 500 feet, she was limited by shortness of breath. So let's listen to Joanie and Paul reflect on how they overcame the difficulties related to fatigue.
My activity level was very limited. I couldn't lift them.
Yeah.
And getting up and down off the floor even was hard.
Mm-hmm.
The fatigue is just there all the time, but I've been swimming a lot. And I snorkel in my pool, and I think people think, here comes the lady with the snorkel. But I don't care anymore. So I just go and I swim, and it's been really great for me.
For me, I go back to the one time we were in Hawaii, and you couldn't even walk to the beach. And then this last summer, we went to Europe for 3 weeks, and I think we talked about it was 3 miles per day was the minimum that you walk while we were there. So that's what a great jump to happen, to go from 500 or 300 feet with help and to walk all over Europe.
The reason we presented this case is because there were 2 distinct diagnoses. And the PROMIS scores really helped us zero in on the cancer-associated fatigue. This led to a focus on aerobic conditioning rather than issues related to low back stabilization or mobility. The post-treatment PROMIS scores reflect the outcome. You can notice there's a marked improvement in physical function into the mild limitation range, and fatigue scores were at the cusp of transitioning from moderate to mild. And her self-report of walking up to 3 miles per day on her recent trip to Europe was fantastic. So although fatigue is complicated, let's listen to some videos of providers talk about what's kept them from throwing in the white towel.
So if you think about fatigue and what it is, and I never really knew what that meant, people just say I'm tired, but I think it can mean so many different things. So when an intake paperwork comes in and it says thyroid problems or hypothyroid, or I see in their medication there's thyroid stuff, I actually ask them, like, how do you feel like that's managed? And I've actually said, or had patients say, I don't feel like it is managed, and nobody's ever asked me about this. Cardiovascular system, I always ask about physical activity. If they say I don't really do that, then that's like a huge kicker. I want you to go walk 10 to 15 to 20 minutes a day. Then you look at sleep. I've had patients that fatigue scores were just not getting better, and they went for blood work, nothing was popping up. Eventually we said, go for a sleep apnea test. And then depression, anxiety, so we do screen for that.
I think fatigue is an important one to have a discussion with your patients, because I think a lot of healthcare providers don't know how to address it. Like you did a very clinical decision making or systemic viewpoint of looking at the cardiovascular or looking at the endocrine system or even looking at behavior or psychological.
Right.
I think you do a great job with that, and I think the patients appreciate you walking through it with them. And I think the general practitioner or the PCP also appreciates that, that you're following through and trying to figure out why they have, fatigue.
So what we're learning is that having a model of fatigue that includes biomedical causes, sleep quality, mental health, and physical activity helps us focus in where to direct care and try to move the fatigue symptoms the patient's experiencing. And that concludes this module of the Beyond Biopsychosocial Training Program.